Hello, everyone. Welcome to week 8, where we're going to talk about psilocybin. We're going to talk about it for the next couple of weeks, but this week we're going to talk about it specifically in its application to major depressive disorder, treatment-resistant depression, and oncology. We'll talk about different applications for it next week, and then we'll get the next several weeks are going to be substance specific. So, chapter 9, aptly called psilocybin. Let's talk about its history and its action, its mechanism of action. And some of this will be review from what we've covered, but I want to make sure that you are well versed in the differences amongst these substances as well. All right. So like I said, this starts our 2-week focus on psilocybin. So today we're going to ground ourselves in history, anthropology, pharmacology, and early clinical research before we move to some more applied therapeutic models next week. So it's important to recognize that psilocybin is not simply a molecule, it's an indigenous sacrament. It's a colonially suppressed medicine. It is a counterculture symbol. It is a Schedule 1 substance, and now it's a breakthrough designated investigational psychiatric treatment. Understanding this arc helps us to situate psychedelic therapy within broader systemic, political, and ethical contexts. All right, so psilocybin containing mushrooms include over 200 species. Most belong to the Psilocybe genus. They grow worldwide but are particularly concentrated in Mexico and Central America. The two primary psychoactive alkaloids are psilocybin, which is a prodrug, and psilocin, which is the active metabolite. Notice that long before Western psychiatry identified receptor binding profiles, indigenous communities identified these organisms as powerful agents of healing and spiritual encounter. So, as systemic thinkers, we must ask who gets to define medicine? Who gets erased from that narrative? So, evidence suggests ritual medicine has been used for thousands of years. It was used thousands of years ago. The Aztecs referred to mushrooms as God's flesh. Ceremonies were used to treat illness, to seek spiritual insight, to access divine knowledge. And this framing matters clinically. Modern trials often describe mystical experience using psychometric language, but indigenous cultures never conceptualized these states as side effects, they were the point. Spanish colonization violently suppressed mushroom ceremonies. Indigenous ritual was reframed as devil worship. Artifacts were destroyed, practitioners were persecuted. For 4 centuries, mushroom ceremonies continued underground. As we move toward medicalization today, we must examine, are we restoring something or repeating extraction under biomedical authority? So in 1955, R. Gordon Wasson participated in a ceremony led by Maria Sabina, a Mazatec healer. His 1957 Life magazine article introduced psilocybin to mainstream Western audiences. This moment catalyzed scientific research, counterculture adoption, and it also increased tourism to Oaxaca. It also disrupted Mazatec communities and brought unwanted attention. This is a critical ethical teaching moment in our field. Swiss chemist Albert Hofmann isolated and synthesized psilocybin. Sandoz distributed it under the name indocybin to physicians and researchers. This marks the beginning of psychedelic psychiatry. However, political backlash in the 1960s led to withdrawal from market and increasing restriction. So in 1970, the Controlled Substances Act placed psilocybin in Schedule 1 alongside heroin. Schedule 1 means it has a high abuse potential, there's no accepted medical use, and there's a lack of safety under supervision. Importantly, this classification was political, not pharmacologically driven. Research funding evaporated, and investigators were marginalized. Psilocybin is dephosphorylated into psilocin, which crosses the blood-brain barrier. Primary action, as we know, is the 5-HT2A receptor agonist, or it's an agonism. It blocks, or blocking 5-HT2A receptors abolishes psychedelic effects. The onset is typically 20 to 40 minutes, with peak experience around 60 to 90 minutes. The total duration of the experience is 6 to 8 hours when taken orally. Dose, set, and setting, as we know, profoundly shape experience. Psilocybin increases glutamatergic signaling in the prefrontal cortex, leading to increased BDNF, or brain-derived neurotrophic factor. BDNF supports synaptic plasticity, memory formation, and adaptive learning. So, unlike SSRIs, which require weeks, psilocybin may produce rapid antidepressant effects after 1 or 2 sessions. This raises a central clinical question. What stabilizes these gains? Likely the relational and integrative process. The Mystical Experience Questionnaire, or the MEQ, measures, as we know, oceanic unity, noetic quality, sacredness, ineffability, and positive mood. So, across cancer and depression trials, intensity of mystical experience, it correlates with symptom improvement. This suggests that the subjective experience is not incidental, it may mediate therapeutic change. So psilocybin has, in terms of its safety profile, very low physiological toxicity, no significant addiction liability, no organ damage, no known lethal overdose in humans. So primary risks are psychological. They can be panic, paranoia, and acute anxiety. Modern trials mitigate risk by screening, preparation, having a supportive environment, and also engaging in integration. So, HPPD, or hallucinogen persisting perception disorder, is rare and more common in unsupervised or polysubstance contexts. Symptoms include visual trails, halos, visual snow, and evidence suggests it is significantly less common in research settings. So, reality testing remains intact. So, trials at Johns Hopkins, NYU, and UCLA have demonstrated large effect sizes, rapid reductions in anxiety and depression, and sustained improvement at 6 months. Participants frequently rated sessions among the most meaningful experiences of their lives, and then existential distress decreased significantly. So you can see in this slide also, this is a setup. I would say like a relatively typical setup. The one that we did in the trial that I was a part of was in a hospital room, so a little bit more clinical. But generally, what's happening is you have a participant who has eye shades on. They have headphones with a preset playlist. The playlist is actually on Spotify. I think it's like Johns Hopkins psilocybin trial playlist or something like that. So you can see it's a lot of like classical music, non-lyric music, because they don't want like any of the words to influence the experience. And then generally what's happened is there is a gender difference co-therapy team, generally a woman and a man. I don't know of any other genders in terms of like what has happened or existed in trials. But yeah, usually like light, dimmable lights, comfortable. You can see this person is on a pillow, they're covered, they, are in what is hopefully a relatively comfortable position. Also, my PI and I sat farther away from the participant than this. Like this would be a little too close for me as a participant. Also, probably as a guide, a little too close. So we were about like 5 feet away from the client or the participant. Same side though, so they would be up against this wall, and we were sitting on chairs about 5 feet to their right. All right, so tobacco and alcohol. Tobacco cessation trials at Johns Hopkins reported abstinence rates far exceeding current pharmacotherapies. Alcohol trials demonstrated decreased heavy drinking days and increased abstinence. These treatments combine preparation, a psilocybin session, and integration. They also use motivational interviewing or CBT as their like therapeutic theory. Again, drug alone is not the model, it's psychedelic assisted psychotherapy. So then talking about cocaine and opioids. So there are currently no FDA approved medications for cocaine use disorder. This was the substance or like the addiction that we were treating in the trial that I was a part of. So emerging trials like at the University of Alabama at Birmingham, we should be publishing hopefully this semester. It just should come out sometime in the next like couple of months. Emerging trials are investigating psilocybin for cocaine addiction. I don't know if there's any other trials aside from the one that I was a part of. And then given rising overdose rates and stimulant use trends, this is a critical area for future research. I know that for opioids, there is a clinical trial currently happening at the University of Wisconsin-Madison. I think maybe in New Mexico too. I'm not totally sure. So open label studies show rapid and sustained reductions in depressive symptoms. Phase 2B and 3 trials are underway. If successful, psilocybin could become the second rapid acting antidepressant after ketamine, but with lower abuse liability and potentially longer durability. I believe now, so like this book was published, I think in 2021. I think now the phase 2, we've moved from the phase 2, and I actually think I'm pretty confident. I think I just saw a news release about this like last week or something like that, that Compass Pathways out of the UK just finished their phase 3 trial with psilocybin and depression. So like they were further along than what was published in this textbook. All right. So the Good Friday experiment demonstrated that psilocybin could reliably occasion mystical experiences in religious trainees. Follow-up decades later showed sustained positive changes. So the replication at Johns Hopkins confirmed these findings under modern controls. So this research links spirituality and therapeutic change in measurable ways. So if phase 3 trials are successful, which the largest or the first kind of phase 3 trial coming out of Compass Pathways was deemed by the researchers as successful, rescheduling may occur. Psilocybin may be available by prescription. REMS programs will regulate distribution. Specialized psychedelic clinics will emerge. And so this will require therapist training standards, ethical frameworks, cultural humility, and systemic awareness. But we'll see, because as we know, the history with psychedelics is political, not necessarily scientific. So for our field of couple and family therapy, key questions include, how does a mystical experience reorganize relational patterns? Can shared psychedelic experiences transform attachment bonds? What responsibilities do we carry in integrating indigenous medicines into Western systems? And like I said, next week, we'll move into therapeutic models and integration frameworks. So next article, or next chapter, the treatment of depressive disorders with psychedelics. So this is chapter 26 from our reading. So we're going to look at how psychedelic assisted therapies have been studied in relation to depressive disorders, both historically and in the contemporary Renaissance. The chapter begins with depression as a global health problem and argues that because depression is heterogeneous, meaning it looks different in different people, our treatments often struggle to be universally effective. Then the chapter moves into the early era of psychedelic research, primarily with LSD, where investigators noticed possible antidepressant effects early on, but most of those studies do not meet modern methodological standards. After that comes the underground period, where legal barriers and politics largely shut down legitimate research, even while some clinicians continue to work illegally. The most important contemporary section is the evidence base we actually have right now. Open label psilocybin trials in treatment resistant depression, small RCTs in cancer related distress cohorts, and early work with ayahuasca. And then the chapter turns to mechanisms, not simply what receptors does it bind to, but how context, the quality of experience, and a felt renewal of connection may be central to therapeutic change. Finally, we'll stay honest about the methodological problems. Blinding is extremely hard. Placebo response is powerful in depression, and psychedelic experiences amplify meaning and expectation. So the chapter is asking us to hold both hope and rigor at the same time. So let's start with the scope of the problem. Depression is one of the most burdensome medical and social challenges worldwide. The chapter cites lifetime prevalence estimates around 10 to 15%, which is enormous when you consider this is not a niche condition. It's something that touches nearly every family system in some way. Globally, the number of people living with depression has been estimated in the hundreds of millions. The chapter emphasizes that prevalence has increased substantially over time and is projected to keep rising. That matters for us not only clinically, but systemically. Depression isn't only an individual diagnosis, it's a public health issue that intersects with economics, caregiving, trauma exposure, and access to resources. It's also a major contributor to years lost to disability. In other words, even when depression doesn't kill someone directly, it can steal functioning, meaning, relationship quality, work capacity, and health. And critically, depression is strongly linked to suicide, which is a leading cause of death among young people globally. So the setup is here. We need better treatments, faster treatments, and treatments that address more than symptom suppression, especially for people who don't respond to existing interventions. The chapter makes a key point that's easy to overlook. Depression is not a single uniform illness. Some people can't sleep at all. Insomnia is common, while others, especially younger adults, may experience hypersomnia. Some people have one episode in their lifetime, while others experience depression for decades. A really important conceptual proposal appears here. Depression may be less about one specific checklist of symptoms and more about a tendency to fall into negative mood states and have difficulty recovering from them. That inability to recover framing is useful because it's compatible with models involving rumination, rigid cognition, and stuck relational loops. The chapter also reminds us that depressive episodes can be secondary to underlying medical conditions. Endocrine disorders, inflammatory conditions, neurodegenerative processes, substance misuse, even cancer. This is one reason psychedelic trials often screen carefully. Depression is heterogeneous biologically and contextually. Finally, depression is closely related to other psychiatric conditions like schizophrenia, where depressive symptoms are common, and bipolar disorder, where depressive episodes alternate with mania. This leads to an important trial design issue. Bipolar disorder is typically excluded from psilocybin depression trials because of mania risk, and we'll talk about that later. Here, the chapter underscores something that matters when we interpret modern data. Current trials are not studying depression in general, they are studying carefully screened subgroups. Bipolar disorder is generally excluded in trials focused on major depressive disorder because antidepressant interventions, pharmacological or psychedelic, can risk triggering mania or psychosis in vulnerable individuals. Similarly, modern psychedelic trials usually exclude people with histories of psychosis or strong familial risk of psychotic disorders. This means contemporary studies are sampling a different clinical population than early psychedelic studies, which sometimes included patients we would now exclude, or participants we would now exclude. That affects how we compare historical and modern findings. So we're balancing two priorities: safety and ethical responsibility, and generalizability to the real world. So a key skill here is to be able to hold both at once when you're evaluating the evidence. The chapter traces antidepressant interest back to the earliest LSD literature. Within only a couple of years of LSD's discovery, reports suggested LSD could produce euphoria and might have antidepressant potential. But these early studies were case series, tiny samples, unclear diagnostic categories, and vague outcome criteria. 2 of the 5 depressives, improving sounds interesting, but scientifically it's weak. There's no control group, unclear definitions, and strong susceptibility to expectancy effects and clinician and enthusiasm. Still, this is historically important because it shows from the beginning clinicians suspected that psychedelic experiences might shift mood and cognition in a way relevant to depression. The chapter highlights end of life distress as a bridge between early and modern research. Two historical cancer studies were discussed, one where patients with terminal cancer received very high doses of LSD, and another where DPD was used alongside psychotherapy. What's notable is not only the reported improvements, but the structure. These studies included substantial psychotherapeutic preparation and post-session aftercare, sometimes around 10 hours. That's a key theme in psychedelic therapy. The medicine is embedded in a psychotherapeutic container. Even though these studies lacked placebo controls, they inform the modern emphasis on preparation and integration. The field is, in some ways, returning to what early clinicians learned through practice. The experience itself and its processing matter. A systemic review of early studies reported clinician-judged improvement in more than three-fourths of patients with unipolar mood disorders. This sounds impressive until we examine the limitations. Most studies lack standardized measures, so improvement could mean anything. Diagnoses were often depressive neurosis or psychoneurotic depression, categories that don't map cleanly onto modern DSM definitions. So the chapter's stance is balanced. We cannot conclude efficacy by today's standards, but there was enough repeated observation of potential benefit to justify renewed investigation, especially given the massive burden of depression and limitations of current treatments. Among early studies, the Spring Grove and Maryland Psychiatric Research Center work stands out as comparatively sophisticated. They included weeks of preparatory interviews, a two-therapist model, and purposeful use of music and visual stimuli. And they emphasized prolonged follow-up sessions to integrate the experience. They also included control groups and randomized group selection, still not perfect by modern standards, but notably stronger than many early reports. Reported improvement rates were around 80%. This is a really important point for y'all. Many modern elements, so two-therapist dyad, music curation, and extended preparation are not new inventions. They have historical precedent, and modern protocols refine them using current ethics and measurement standards. Now we arrive at one of the most important conceptual sections, why randomized controlled trial methodology is uniquely challenged in psychedelic therapy. The RCT is designed to isolate variables, but with psychedelics, the experience is so distinctive that participants often know if they have received the active drug. Once people know, blinding collapses. That creates two major problems. Participant ascertainment bias. If someone realizes they got the placebo, they may be less likely to report improvement. Observer bias. If investigators suspect someone received the active drug, they may unconsciously interpret outcomes more favorably. And beyond bias, there's a deeper issue. The chapter emphasizes that the psychedelic experience is inextricably shaped by set and setting. That means the therapeutic effect is not only pharmacological, it's a synergy between drug and context that's hard to reduce to a simple pill versus placebo design. So this slide defines set and setting explicitly. Again, for y'all, set refers to internal factors like your mood, expectations, intention, and psychological readiness. Setting refers to external factors like your physical space, interpersonal support, safety, and cultural meaning. The chapter argues that because context matters so much, results may not generalize neatly. If a study occurs in a carefully designed therapy room with intensive preparation, we cannot assume similar effects in a different setting. This also reframes historical failures. Older research often neglected context. When the container is weak, outcomes may be weaker or riskier. The modern Renaissance is partly a paradigm shift that treats context as part of the intervention rather than noise. After prohibition and international regulation, research could technically continue with authorization, but practically barriers multiplied. Regulatory burdens, political stigma, a lack of funding, and lack of publishable pathways. This led to the underground era, where some clinicians continued psychedelic assisted therapy illegally. The chapter notes that there's little quality data on risks and benefits, but it is historically notable that clinicians were willing to risk imprisonment because they believed the work was in their patient's best interests. This is ethically complicated. It's not an endorsement, it's an observation that about the strength of conviction and the perceived therapeutic value. For y'all, it's a chance to discuss how moral certainty, clinical intuition, and evidence can diverge and why modern ethical frameworks matter. So, this chapter highlights a rare exception. Switzerland temporarily permitted a training program for LSD and MDMA assisted psychotherapy. This is important historically because it shows that even during Prohibition, there were moments of sanctioned clinical exploration. When the program ended and psycholytic therapy was prohibited again, many clinicians continued underground, mirroring the earlier pattern. This underscores the legal context that shapes clinical possibilities. The same intervention can be seen as legitimate medicine or criminal activity, depending on the policy climate. So, this slide is meant to set expectations. As of the chapter's reference point, multiple large RCTs were underway but not yet published, so the evidence base at the time was limited. We mainly have a handful of open label trials in treatment resistant depression, small RCTs in cancer related existential distress cohorts, and a small open label feasibility study on ayahuasca. So when someone claims psilocybin is proven for depression, the chapter would say, not yet, not definitively. The data are promising, but we need larger controlled trials to establish efficacy and understand who benefits most. So the chapter briefly reviews an open label ayahuasca study in a psychiatric inpatient unit with recurrent major depressive disorder. It's described as feasibility and safety oriented, not efficacy oriented. However, the authors report rapid reductions in depression scores shortly after dosing, suggesting a fast onset signal similar to what's seen in psilocybin and ketamine discussions. One important contrast, this was not delivered in a structured psychotherapy platform and did not emphasize post-treatment psychotherapy sessions in the way psilocybin protocols often do. So for our course, this raises a critical design question. How much of the therapeutic effect is pharmacological versus psychotherapeutic container? Psychedelic therapy may not be one single model. The field may develop multiple models with different levels of psychotherapy integration. So this is one of the centerpiece studies of the chapter, the Imperial College Open Label Trial in Treatment-Resistant Depression. Participants had long-standing illness, often many years, and most had tried multiple prior treatments. The design used an initial lower dose to test tolerability, followed by a higher dose session with therapists present and music playing. Safety-wise, no serious adverse outcomes were reported, but transient side effects were common. Initial anxiety, brief confusion or thought disturbance, mild nausea, headaches, and occasional mild paranoia. Efficacy-wise, remember, it's open label. Everyone improved at 1 week, many met response criteria, and a meaningful portion remained improved at 3 months. The chapter is careful. These findings are promising but required controlled research. Still, the effect sizes reported are large enough that they justify continued investigation. The chapter discusses RCT evidence from terminal or life-threatening cancer cohorts where many participants had depressed mood. These trials show large short-term differences between high-dose psilocybin and active placebo, higher response and remission rates shortly after dosing. At 6 months, many participants still show improvement. However, the chapter cautions us, depressive symptoms in terminal illness are not identical to treatment-resistant depression in otherwise medically stable individuals. So we have to be cautious about extrapolation. The mechanism might overlap, meaning connectedness and fear reduction, but population context matters. Still, the trials strengthen the claim that psilocybin can produce rapid and durable mood changes in at least some clinical contexts. So, depression trials often show large placebo responses, commonly 30 to 40%. Placebo response is not fake. It's psychobiological and relates to expectation, hope, therapeutic contact, and meaning. The chapter notes psychedelics can enhance suggestibility and meaning. That means expectancy effects might be amplified. So, separating true drug effect from context driven benefit becomes difficult, especially when the treatment inherently includes powerful ritual like elements. Then the chapter lists additional scientific pitfalls. The decline effect. The effects tend to shrink with replication over time, and the winner's curse. Early positive studies may overestimate effect sizes, and then the Hawthorne effect. Improvement because participants are being observed and cared for intensively in a trial. So rather than making us cynical, this should make us methodologically humble and more careful about study design. Now we shift into mechanisms. The chapter argues we may not be looking at a depression specific mechanism. Psychedelics appear therapeutically versatile, helping across depression, addiction, and end of life distress, which suggests that they may address a more fundamental process common amongst many conditions. A leading candidate is connectedness, connection to self, to others, the world, and meaning. Depression often involves disconnection, so social withdrawal, numbness, isolation, self criticism, and rumination. Psychedelic therapy may interrupt that. Importantly, context is not just a confound, it may be part of the mechanism. The chapter calls this frontier between spirituality and science provocative and uncomfortable, which I think is exactly right. Psychedelic therapy asks psychiatry to acknowledge non material dimensions of healing without abandoning rigor. So, the peak experience is a recurring mechanism across studies. The chapter highlights work showing that oceanic boundlessness, an experience closely related to what earlier literature called mystical experience, predicts longer term reductions in depressive symptoms. A key nuance: the magnitude of perceptual distortions is less predictive than the quality of the experience, especially unity, transcendence, and emotional breakthrough. This matters for language. Hallucinogen frames the experience as perceptual error. Psychedelic frames it as mind manifesting, an experience that can produce insight, meaning, and psychological reorganization. Clinically, this is why protocols often emphasize inward attention, supportive music, eye shades, and a setting that encourages surrender rather than control. The chapter describes the afterglow as a post-acute period, days to weeks, where mood is elevated, anxiety is reduced, and people feel less burdened by the past. This is theorized as a prime window for integration. In this window, psychotherapy may be especially potent because defenses are softened, and cognitive emotional flexibility may be increased. Neuroimaging findings in the post-acute period are sometimes interpreted as a kind of reset mechanism. The acute state disrupts rigid networks, and the post-acute period allows reintegration in a healthier configuration. The chapter also references emerging preclinical evidence that psychedelics can promote neurogenesis and synaptogenesis, so structural plasticity changes. This is exciting but still developing, and we should be careful not to overclaim. But conceptually, plasticity plus integration is a plausible pathway for durable change after a single or few sessions. A fascinating mechanism is meaning amplification. Psychedelics can make experiences feel deeply significant. Insights feel real, emotions feel momentous, and symbols feel alive. The chapter links this to the idea that placebo effects can be understood as meaning responses. What we believe something means changes physiology and outcomes. This raises ethical questions. If psychedelics amplify meaning, what do we do with that power? Some people worry about veracity. Are the insights true? The chapter suggests a pragmatic ethical frame. If meaning making reduces suffering and improves functioning, it may be unethical to dismiss it purely on philosophical grounds. There's also a cultural feedback loop. Media portrayals shape expectations, expectations shape experiences, and experiences feedback into culture. That means the set of future patients is partially shaped by the stories society tells about psychedelics. The chapter treats music as a core component of psychedelic therapy, as we know, not background ambiance or ambiance. Um, Music can help people relinquish control, enter the inner world, sustain continuity, and facilitate emotional expression. In modern studies, participants' relationship to the music predicts the therapeutic quality of the session. So, three variables are highlighted: liking, did the person like the music? Resonance, did it match or meet their emotional state? And openness, could they allow the music to move them? These predicted mystical type experiences and reductions in depression scores, whereas raw intensity of the drug effects did not. Sorry, so these predicted mystical type experiences and had reductions in depression scores, whereas raw intensity of the drugs did not. So clinically, we should think of music selection and responsiveness as part of treatment fidelity, not decoration. Qualitative work identified two big change processes. First, people move from disconnection to connection, so connection to self, to others, the world, to nature, and to meaning. Depression often narrows life and isolates the person internally and socially. Psychedelic therapy may restore relational embeddedness. Second, people move from avoidance to acceptance. Many describe depression as emotional avoidance, numbing, or rumination that keeps pain at a distance. In session, people often encounter emotions more directly, sometimes with sobbing, trembling, catharsis, and a sense of resolution when they stop resisting. Afterward, people often report a broader emotional repertoire, not just less sadness, but more access to tenderness, gratitude, grief, desire, and aliveness. The chapter also cautions connectedness to nature or spirituality may be beneficial, but if someone leaps to transcendent meaning without integrating personal material, spiritual bypassing can occur. This is why integration is not optional. Ego dissolution is discussed as a major phenomenological feature of high dose psychedelic states and historically linked to therapeutic success. Neuroscience attempts to map this onto changes in networks like the posterior cingulate cortex and broader default mode network connectivity patterns. Increased global connectivity correlates with ego dissolution, suggesting the normal boundaries of self experience become less rigid. Clinically, ego dissolution may be the acute form of connectedness. If self boundaries soften, people may experience unity, compassion, or relational expansion. But the chapter is clear that ego dissolution is as a construct needs more validation, especially across diverse populations. The long-term question is, how does an acute dissolution consolidate into durable improvements? Likely through integration and behavior change in the afterglow window, but we need more data. The chapter ends in a tone of cautious optimism. It does not claim that psychedelics are definitively proven antidepressants. It claims that supervised use appears relatively safe in screened depressed patients and that early signals justify continued research. Mechanistically, psychedelics may engage multiple systems relevant to depression, so neuroplasticity, inflammation, neuroendocrine regulation, plus psychological mechanisms like connectedness, acceptance, and meaning making. The biggest clinical scientific questions remain: who benefits most? Who is harmed or destabilized? What dosing and psychotherapy models are optimal? How do we ethically scale access without commodifying or diluting care? For us couple and family therapists, I'd add, how do these mechanisms play out relationally? Does connectedness include partner relationships, attachment, and family systems? That's where our systemic lens becomes especially valuable. All right, so moving to our articles. So this is a landmark phase 2 trial published in the New England Journal of Medicine in 2022 by Goodwin and colleagues. The study asks a very pragmatic clinical question. If psilocybin is going to be developed as a treatment for treatment-resistant depression, what dose looks most promising and what do we learn from safety and feasibility? Or what do we learn about it? Safety and feasibility. This is a double-blind, randomized parallel group trial, so not a small open-label pilot. Participants with treatment-resistant depression received a single administration of synthetic psilocybin, which is the proprietary formulation of COMP 360 or from Compass Pathways, at either 25 milligrams, 10 milligrams, or 1 milligram, and all groups received structured psychological support. The primary outcome is a classic depression severity measure, the MADRS, looking at change from baseline to week 3, which is an important time point because it's far enough out to see whether there's a clinically meaningful improvement, but still relatively close to the dosing session. So, before we get into methods and results, it helps to anchor why treatment resistant depression is such a big deal clinically and socially. So, in this paper, the authors situate treatment-resistant depression in relation to the reality that remission rates decrease across sequential treatment steps. And many patients end up cycling through multiple medications and augmentation strategies. So, TRD is not just more depression, it's typically associated with longer illness duration, more impairment, and more medical comorbidity, and a higher risk profile, including suicide risk. It's also expensive, more utilization, more disability days, and more indirect costs. So when we hear single dose intervention, the reason the field gets excited is that it raises the question, could there be a model that produces meaningful change without chronic daily dosing? But the trial also asks us to stay grounded. Effectiveness and safety have to be demonstrated carefully, and feasibility has to be shown across sites, not just a single expert center. The purpose here is dose finding. What dose shows the best signal with an acceptable safety profile? This is phase 2, which typically means we're not proving definitive clinical effectiveness for the entire population. Instead, we're looking at signal detection, dosing, safety, and trial feasibility. A major strength is the trial is a multi-site and it's international. There's 22 sites across 10 countries. That matters because psychedelic trials are sometimes criticized for being boutique interventions that only work in a highly specialized setting. This design tests whether a manualized approach can be implemented more widely. Participants are followed for 12 weeks, which is long enough to begin addressing the question, do early improvements persist, fade, or require further intervention? So let's unpack the population. Participants had major depressive disorder without psychotic features and were considered treatment resistant based on failure of 2 to 4 adequate treatments for the current episode. Adequate meaning both dose and duration, with a minimum duration threshold like 8 weeks. A key procedural detail. Participants went through a run-in period where antidepressants and other prohibited CNS acting medications were tapered and discontinued before baseline. This is important because it helps reduce confounding, but it also raises pragmatic questions about generalizability. Many real-world TRD patients are on complex medication regimens, and discontinuation may be challenging. On average, participants started the trial quite symptomatic. It means the MADRS in the low 30s is in the moderate to severe range. That matters because we interpret effect sizes differently depending on baseline severity. So here's the basic sample. 233 participants were randomized and treated, almost evenly split across the 3 dose groups. The average age was about 40 and a bit over half were women. A major limitation explicitly acknowledged is the sample was not ethnically diverse, about 92% white. That affects generalizability and should prompt a discussion about equity, access, and how early phase trials can unintentionally reproduce disparities in who benefits from innovation. This is also a fairly chronic and recurrent sample. Most participants had a current episode longer than a year and multiple lifetime episodes. That profile matters because it's often the harder to treat end of major depressive disorder. Finally, prior psilocybin exposure was low. That reduces concerns that outcomes were driven mainly by prior familiarity or expectation effects amongst experienced psychedelic users, though expectancy and blinding are still major issues in this kind of research. So it's crucial to understand what psilocybin treatment means in this trial. It's not just swallowing a capsule. The intervention includes a manualized psychological support model that spans preparation, support during dosing, and integration. During the run-in and prep period, participants met with a therapist at least 3 times with goals like building rapport, setting expectations, and preparing for the experience. On dosing day, participants spent 6 to 8 hours in the session with 2 therapists present. The room was designed to feel calming and non-clinical, important because set and setting are not just theory, they're operationalized here as part of the standardized treatment environment. Participants listened to a music playlist and wore eye shades, which encourages inward focus. Then participants had integration sessions, one on day 2 and another at week 1. The paper emphasizes that integration aimed to support participants in drawing their own insights, and therapists were advised to remain supportive rather than directive. Randomization was centralized and stratified to reduce imbalance across countries and prior exposure. The control condition is not an inert placebo. It's 1 milligram of psilocybin functioning as a very low dose control. A thoughtful design choice here is the use of remote trained raters for the MADRS who were unaware of group assignments and even some trial details. That's an attempt to protect against rater bias, which can be a huge issue when therapists and participants have strong expectations. Still, blinding is inherently difficult. With psychedelic doses, many participants can likely tell if they had a strong dose, and staff may infer as well. The paper explicitly acknowledges that the intensity difference between 25 milligrams or 10 milligrams and 1 milligram can compromise the double-blind structure. So we might connect this to methodological themes, things like expectancy effects, placebo response, and how psychedelic trials are uniquely vulnerable to unblinding compared to other psychopharmacological trials. So the primary outcome is straightforward, change in the MADRS score from baseline to week 3. This is a clinically meaningful window. It's not just the next day glow, it tests whether improvement persists beyond the acute experience. Secondary outcomes include response and remission at week 3. Response is defined as at least a 50% reduction in MADRS, and remission is an MADRS score of 10 or less. They also look at sustained response through week 12. That measure matters because the big hope in psychedelic therapy is not only rapid improvement, but also durability. But durability is a higher bar. It's easy to see short-term changes in mood after a profound experience. The clinical question is what happens as life stress returns. The schedule includes multiple follow-up points at day 2, week 1, week 3, week 6, week 9, and week 12, allowing them to track symptom trajectory over time. So the headline finding here, the 25 milligram group improved more than the 1 milligram group by week 3. In least squares mean change from baseline to week 3, the 25 milligram group dropped about 12 points, the 10 milligram group about 8, and the control about 5. The key comparison is a difference versus control. 25 milligrams beat 1 milligram by 6.6 points, and that was statistically significant with a p-value of less than 0.001. By contrast, 10 milligrams did not significantly differ from 1 milligram. Clinically, you can translate this as there appears to be a dose-response relationship where 25 milligrams produces a stronger antidepressant signal than the low-dose control, but 10 milligrams may be closer to control than to 25 milligrams at the week 3 time point. So secondary outcome mostly move in the same direction as a primary outcome, especially for 25 milligrams at week 3. Response rates at week 3 were 37% for 25 milligrams compared to 18% for control, and remission was 29% for 25 milligrams versus 8% for control. However, a critical statistical nuance. The trial used a hierarchical testing procedure to control type 1 error. Because the 10 milligram comparison did not reach significance for the primary endpoint, the later secondary endpoints are not treated as definitively significant in the pre-specified testing sequence. So while the numbers are suggestive, the authors are careful not to overclaim. The sustained response at week 12 is especially important. The 25 milligram group shows 20% sustained response, but the confidence intervals in the testing structure mean we should interpret durability cautiously. This is a great discussion point, if you'd like. If a single dose improves symptoms rapidly, but many people do not maintain response through 12 weeks, what does that imply about optimal dosing schedules, integration intensity, or booster sessions? The study is not designed to answer those questions, but raises them. Safety is not an afterthought here, it's central. Most participants across all groups reported at least one adverse event, with the highest proportion in the 25 milligram group. On dosing day, the most common adverse effects with 25 milligrams were headache and nausea. Some participants also reported dizziness and fatigue. Notably, only one participant required an acute that required Lazopram on day one. That detail matters because it suggests that the trial's support model, severe acute anxiety requiring medication, was uncommon, at least recorded here. Still, adverse events were common overall. And the question becomes not, are there any adverse events, but what types of events, how severe, how manageable, and how do they compare to existing treatments for TRD? So this is one of the most clinically sobering parts of the paper. Suicidal ideation or behavior and self-injury events occurred in all dose groups. And serious adverse events related to suicidality appeared more frequently with the higher dose groups during certain windows. From day 2 to week 3, serious adverse events were reported in the 25 milligram and 10 milligram groups, including suicidal ideation and intentional self-injury. And there was one hospitalization for severe depression in the 10 milligram group. No serious adverse events were reported in that window for the 1 milligram group. Importantly, baseline suicidal ideation was present in a substantial proportion of participants across groups, but the trial excluded persons judged to be clinically significant risk for suicide. So even with that exclusion, suicidality remained a significant monitoring issue. The author's takeaway is cautious and direct. Future trials must treat suicidality as an area requiring clinical vigilance, not simply an incidental risk. So this is a key point for ethical framing. Excitement about rapid symptom reduction must be balanced with careful attention to adverse outcomes and the complexity of TRD populations. So what can we responsibly conclude? First, it demonstrates feasibility. You can run a standardized, manualized psilocybin-assisted model across many international sites and follow participants out to 12 weeks. That matters for translation beyond a small number of expert centers. Second, there is a clear signal at 25 milligrams relative to 1 milligram at week 3, and 10 milligrams does not show the same separation. That implies dose matters, and it supports moving forward with 25 milligrams as a candidate dose for later phase evaluation. Third, this is not the final word. We still need trials that are larger, longer, and ideally include active comparators. So, for example, comparison against standard treatments. We also need better ways of addressing blinding, expectancy, and more diverse recruitment. The authors acknowledge several limitations that we should treat as central, not peripheral. One is the lack of an active comparator. Without that, it's hard to benchmark the effect size and risk profile against current TRD options. Second, the lack of diversity is a major constraint and a call for action for how future trials recruit and engage communities historically excluded from research. Third, excluding participants at significant suicide risk is ethically understandable, but it creates a gap. TRD in the real world often involves high suicide risk, so we're left asking how this model would perform in higher risk populations and what extra safeguards would be needed. Fourth, blinding is a persistent issue. Psychedelic intensity can reveal group assignment, and finally, the durability question remains open. Benefits at week 3 are meaningful, but sustained benefit through week 12 is not firmly demonstrated in this trial design and statistical framework. From a clinical training perspective, the biggest takeaway is that psilocybin here is not simply a pill. It's delivered within a structured relational container of preparation, support, and integration. That means therapist competence, team-based delivery, and protocol fidelity are part of what's being tested. Second, safety monitoring can be limited to the dosing session. Suicidality and self-harm events occurred in follow-up windows, meaning post-session care planning and monitoring matter. Finally, the trial points toward the next wave of research, active comparisons to existing treatments, longer follow up, thoughtful methods to address unblinding, and a serious commitment to equitable recruitment and culturally responsive care. So you might, uh, I might ask a question here of what would responsible scale up look like clinically, ethically, and systemically if 25 milligrams remains the leading dose in future trials. All right, our last reading, and I'm going to do a little bit of comparison of these two articles that we read about the two studies. All right, so single dose psilocybin for MDD, an RCT. This is looking at the treatment of depressive disorders with psychedelics, how we got here historically, and the contemporary evidence, what the contemporary evidence actually shows, and what we can versus cannot responsibly conclude. I want us to hold two truths at once. Depression is enormously common and disabling, and also clinically heterogeneous. So any one-size-fits-all claim about treatment should raise our eyebrows. Psychedelic assisted therapy has a long history, including early LSD era case series, and cancer distress work, followed by prohibition and a long underground period, and then a resurgence with modern trials. So I want to talk through the burden and complexity of depression, early psychedelic studies and why they're hard to interpret by modern standards, and contemporary trials and what they suggest about antidepressant effects and durability. Then talking about proposed psychological and neurobiological mechanisms and methodological challenges, especially blinding, expectancy, and adverse events. All right. So depression is consistently described as one of the most burdensome health issues worldwide. Um, and we've covered, I'm going to be repeating many of this. Even conservative estimates often place lifetime prevalence around 10 to 15%, as we talked about, meaning most clinicians will encounter depression constantly across settings. Beyond prevalence, depression is a leading driver for disability. So even when it isn't fatal, it's deeply impairing to daily functioning, relationships, work, and physical health. It carries enormous societal costs like medical utilization, productivity losses, caregiver burden, and the compounding effects on families. And importantly, depression is strongly associated with suicide risk, with youth and young adults particularly vulnerable. So this matters because any intervention claiming rapid and durable antidepressant effects, especially after one or two administrations, can naturally generate excitement, but it also demands careful safety, monitoring, and strong evidence. Okay, so I'm gonna pause for just a second. Okay, I'm back. I skipped a few slides because they were a little redundant. But anyway, so going to the Racine et al. Study. So they conducted a multi-site phase 2 randomized trial in major depressive disorder, comparing a single dose of 25 milligrams of synthetic psilocybin to 100 milligrams of niacin as an active placebo. This is an important design choice because it attempts to address critiques of earlier studies like small sample sizes, open label designs, and rater unblinding by using multiple sites and a comparator that produces noticeable physical sensations. Participants received psychological support, and outcomes were assessed by central raters through about 6 weeks. The primary endpoint was change in MADRS from baseline to day 43, with key secondary endpoints including earlier change and functional impairment. As a design, this trial is a step toward better durability measurement and broader generalizability than single site pilots. though it still has typical exclusions like psychosis and mania histories and active substance use disorder and suicidal intent that shape who the findings apply to. So results wise, psilocybin was associated with significantly greater reductions in MADRS scores than niacin from baseline to day 43, and also showed a significant benefit by day 8, supporting the rapid onset signal. Importantly, the study also measured function, not just symptoms. The psilocybin group showed greater improvement on the Sheehan Disability Scale, which helps connect symptom change to daily life impact. On categorical outcomes, more participants receiving psilocybin met criteria for sustained response, while remission findings were more mixed depending on definitions and time points. Safety wise, there were no serious treatment emergent adverse events reported, but psilocybin had a higher rate of overall and severe adverse events compared to niacin, many clustered around the dosing period. Clinically, that combination, meaningful symptom and functional improvement alongside noticeably acute or noticeable acute adverse events, reinforces that this is not a causal intervention. It's a medically and psychologically intensive procedure. So, this is a great methods teaching paper because the authors name several limitations that are central to the whole field. First, they did not assess blinding success, and given the noticeable psychoactive effects, functional unblinding is likely. These matter, or that matters because unblinding can inflate treatment effects through expectancy and can differentially affect dropout. If someone realizes they got niacin, they may disengage, which can bias comparisons. Second, adverse event assessment. So, standard AE or adverse event tools may not fully capture psychedelic specific harms like emergent spiritual or existential distress, relationship destabilization, manic switching risk in vulnerable individuals, or prolonged perceptual issues, especially if not systematically solicited. Third, generalizability. The trial excludes several high complexity groups we see in practice, including those with psychosis or mania history, active SUD, sorry about that, and suicidal intent. Oh, shoot. Where did I go? Whoop. I went too far. Okay, here we go. Fourth, equity. The paper explicitly points to the need for strategies that increase recruitment and retention from racially and ethnically minoritized populations and other underrepresented groups, because otherwise we risk building an evidence base that doesn't apply fairly. So, what's the reasonable translation or responsible translation? We can say controlled studies support a promising antidepressant signal for some patients when psilocybin is administered with psychological support and carefully designed protocols. We cannot say psilocybin is just another antidepressant pill that can be prescribed and sent home because the intervention includes a whole delivery system: screening, preparation, supervised dosing, and integration, plus safety monitoring. Another point we have to teach explicitly is that outcomes likely depend on context and therapeutic skill, which means implementation is a clinical governance issue. Who is qualified? What training is required? What emergency pathways exist? How do we prevent boundary violations? And how do we ensure continuity of care for non-responders or those with emergent risk? The research is moving fast, but the clinical infrastructure has to move responsibly. All right, if we want this field to mature, several things are non-negotiable. We need better ways to measure and manage unblinding. At a minimum, assess blinding success and measure expectancy. We need longer follow-up because depression is often chronic and relapse prone. 6 weeks is informative, but not definitive for long-term utility. We also need better adverse events taxonomies that capture the kinds of harms people actually report in psychedelic experience, not just standard side effects like headache and nausea. Comparative effectiveness will matter too. Not only psilocybin versus placebo, but psilocybin assisted therapy versus the best existing treatments, including psychotherapy, SSRIs or SNRIs, and other rapid acting interventions like ketamine. And equity can't be a side project. It has to be designed into recruitment, retention, and community partnership from the beginning. So the last thing I wanted to do for y'all is just like compare the two articles that we read, the two studies. Um, so first is the Goodwin 2022, which is best conceptualized as a dose-finding TRD trial. The clinical population here is treatment-resistant depression, meaning participants have typically failed multiple prior interventions and carry higher baseline chronicity and risk burden. The design compares three psilocybin doses, 25 milligrams, 10 milligrams, and a very low 1 milligram condition. So the central question is dose response. Does a fully psychedelic dose outperform a minimal dose comparator? The primary endpoint is improvement on the MADRS around 3 weeks. So this is about dose differentiation and safety and feasibility in TRD, not about proving generalizability to all MDD. All right, so the 25 milligrams separated from the 1 milligram, and 10 milligrams had essentially no effect categorically. So the follow-up extends beyond the acute window, but we treat longer-term signals as more exploratory in phase 2. So it's the Goodwin article is about TRD, it's dose ranging, and the control is 1 milligram psilocybin, not niacin, like in racin. That matters because the experiential difference between 25 milligrams and 1 milligram is often obvious, which re-raises the blinding problem. Also, TRD participants often have long illness duration and multiple prior failures, so outcomes are clinically meaningful but also vulnerable to complexity. The function of this paper is the evidence ecosystem. In the evidence ecosystem is identify a dose with the best efficacy safety trade-off to justify phase 3 and refine protocol decisions. All right, so Goodwin highlights that safety is not confined to the dosing day. So there are acute side effects like headache and nausea, but more importantly, severe and serious adverse events occurred. So TRD populations carry risk, and psychedelic interventions can produce intense experiences and potential disappointment if they don't work. So safety planning must include screening, ongoing risk assessment, clear escalation pathways, and continuity of care, not a one and done model. All right, so the other trial, it's this is about MDD. It's multi-site and it compares psilocybin to niacin, an active placebo that produces noticeable physical sensations and is meant to partially protect blinding. The endpoint is also different. The primary outcome is change in MADRS through day 43, which is longer than the Goodwin primary endpoint. So racin functions as a stronger general MDD efficacy signal than Goodwin's study. While still being phase 2, the core question is, does a dose of 25 milligrams um, deliver what's with support produce, I'm sorry. The core question is, does a single 25 milligram dose delivered with support produce sustained improvement beyond an active placebo? So Racin's results provide a clearer psilocybin versus active placebo efficacy story. The psilocybin group improved more than the niacin group in the MADRS by day 43, and there's evidence of earlier separation as well. A key strength to emphasize is about measured function, not only symptoms. Symptom change without functional recovery can be clinically hollow. Improvement on the Sheehan disability scale ties effects to real-world life domains. Conceptually, Racin supports the idea that psilocybin-assisted treatment may offer rapid improvement with effects that can extend across several weeks, again, within the structure of a supported protocol. Racin stands out for 3 reasons. There's an active placebo, it's multi-site, and the longer primary endpoint window. The niacin comparator is a methodological choice to reduce simple expectancy artifacts, though it doesn't fully solve functional unblinding. Multi-site design matters because it approximates how treatment might scale, though still within research constraints. And while no serious treatment emergent adverse events were reported, psilocybin still had more overall and severe adverse events, often clustered around dosing and the immediate aftermath. That supports the message that this intervention is tolerable in trials and with screening and support, but it is still an intensive medical psychological procedure. So the critique emphasis for racin is different than Goodwin. With Goodwin, safety and TRD is the highlight. With racin, the main methodological conversation is blinding integrity wasn't directly assessed, and expectancy may still play a significant role. Dropout patterns can also bias effect estimates. And as with most trials, exclusions shape generalizability. So these findings apply best to screened MDD populations, not necessarily to patients with high comorbidity, active substance use, or bipolar spectrum risk. Another key teaching point here is that standard adverse event frameworks may underdetect psychedelic specific harms like prolonged existential distress, relationship destabilization, or emergent manic symptoms in vulnerable individuals, unless those are systematically solicited. And then also, I just wanted to give you kind of a side by side. The clean separation is that Goodwin is a TRD dose ranging study with a very low dose psilocybin comparator and a primary endpoint at about 3 weeks. And that's especially important for safety vigilance and dose selection. Racin is MDD, multi-site, and uses niacin active placebo with a longer primary endpoint at day 43, offering a stronger test of whether a single 25 milligram session outperforms an active comparator across several weeks. So we do not cite Goodwin as the MDD active placebo trial, and we do not cite Racin as the dose ranging TRD trial. These are answering different questions.